Good morning, students. Welcome to today's lecture. Today we are going to have the final part of our topic, cyst of jaws and soft tissues. At the end of today's lecture, we will be able to describe the clinico-pathological aspects of dentigerous cyst and odontogenic keratocyst in detail. We will be able to identify, illustrate, and differentiate the pathological features of dentigerous cyst and odontogenic cyst. We will be able to recognize the significance of a histopathologic report of cystic lesion and suggest the treatment options. Before we begin with our topic, it is important to revise the classification of cysts of the head and neck. Understanding of this classification will help a great deal to understand the individual cysts in detail. So, cysts can be broadly classified as non-odoepithelial cysts and epithelial cysts. As we have already discussed, the non-epithelial cysts are devoid of an epithelial lining and are also referred to as pseudocysts, whereas epithelial cysts are true cysts which would present with a lining epithelium. Epithelial cysts, on the other hand, can be further classified into odontogenic cysts and non-odontogenic cysts. Based on the pathogenesis, odontogenic cysts are further classified under developmental cysts and inflammatory cysts. Previous week we had discussed in detail about radicular cyst, which is a common inflammatory odontogenic cyst. The topic that we are going to discuss today has been categorized under developmental cysts. So this provides us with a clue that the cysts are developmental in origin. Here you can see an illustration showing the different cysts which can occur in relation to the jaw. The topic which we are going to study today shows a cyst which occurs exclusively in relation to the crown of an impacted tooth. This is the dentigerous cyst. On the other hand, we would come across cysts which have a large growth potential and shows a characteristic radiographic appearance. This is the odontogenic keratocyst. So, to begin with dentigerous cyst, let us understand some key concepts. The term dentigenous means bearing teeth or structures resembling cyst. As we are already aware, cyst is a pathological cavity which may or may not be lined by epithelium and contains fluid, semi-fluid or gaseous content, but not the accumulation of pus. So a dentigerous cyst is a cyst which encloses the crown of an unerupted tooth by expansion of its follicle and is attached to the neck of the tooth. So here you can see an illustration of a dentigerous cyst which is formed around the crown of an impacted tooth, and this shows a characteristic attachment to the neck of the tooth. The dentigerous cyst is a common odontogenic cyst. Sometimes these cysts are also referred to as follicular cyst. The dentigerous cyst may enclose a part of the crown or the entire crown of the unerupted tooth. It has to be noted here that the dentigerous cyst shows a characteristic attachment of the cystic capsule to the neck, that is the cemento-enamel junction of the tooth. Knowing this fact helps us in identifying these types of cysts. So, the dentigerous cysts are commonly encountered in the second and third decades of life. These cysts are more common in males as compared to females. The common sites of occurrence is the mandibular third molar. This is followed by the maxillary canine and the maxillary third molar. Here we have to understand that the common site of occurrence is related to the commonly impacted tooth. As we are already aware, the mandibular third molar is the common tooth to be impacted. Dentigerous cyst can occur only in relation to an impacted or unerupted tooth. Hence, its occurrence will also match with that of the types of impaction. Dentigerous cysts are usually asymptomatic, but in cases when the lesion becomes large, they may cause displacement of the adjacent tooth or resorption of the root of the adjacent tooth, and sometimes it can cause pain by compression of the nerves. So here is an illustration of a dentigerous cyst, and it is impacted or unerupted. To understand the pathogenesis of dentigerous cyst, we should also revise some key topics. We have to understand the process of odontogenesis. The process of odontogenesis has been described for all the other forms of cysts as well. So, during the development of tooth, we would have come across a bilayered structure, a bilayered epithelium which is enclosing the crown of a newly formed tooth. Yes, this bilayered structure is also referred to as the reduced enamel epithelium. During odontogenesis, once the formation of the crown is complete, the outer enamel epithelium and the inner enamel epithelium will fuse to form this bilayered structure, also referred to as the reduced enamel epithelium. The reduced enamel epithelium is formed during the protective stage of amelogenesis when the formation of crown is complete. This epithelium basically protects the crown from undergoing resorption within the bone. So the pathogenesis of dentigerous cyst is related or is derived from this reduced enamel epithelium. The cyst is thought to be originating via the accumulation of fluid between the reduced enamel epithelium and the crown of the tooth. Fluid from the adjoining area would move into the space between the reduced enamel epithelium and the crown such that it results in expansion of the cyst away from the tooth. Normally, when the tooth has not erupted, it will be covered by what we know as the dental follicle. The dental follicle is composed of this reduced enamel epithelium, which is further enclosed by a thick connective tissue follicle. This is what we refer to as the dental follicle. We have already discussed that there is accumulation of fluid between this dental follicle and the tooth. So how does this fluid accumulate here? There are various theories proposed to suggest this accumulation of the fluid. The commonly accepted hypothesis suggests that there is compression of follicle by the potential eruption of a tooth. The force of eruption of an impacted or unerupted tooth will create some compression in this dental follicle, which will increase the venous pressure within the follicle. The increased venous pressure will result in transudation of fluid. It is this fluid which gets collected between the reduced enamel epithelium and the tooth surface. This is what results in the formation of dentigerous cyst. The dentigerous cyst displays a characteristic radiographic feature which helps to narrow down the clinical diagnosis. In some instances, we can reach at a definite clinical diagnosis based on the radiographic features. Dentigerous cyst usually presents as a well-defined unilocular radiolucency. The margins are well-defined and sclerotic in nature. As we have discussed, the association of the cyst with the crown of the tooth is observed within the radiograph. But To diagnose it or to understand that the cyst is a dentigerous cyst, we should remember this feature that the cystic wall shows a characteristic attachment to the neck of the tooth. So the radiographic feature shows the margin of the cyst is attached to the neck of the tooth. So this helps us in identifying that the cyst is a dentigerous cyst. This was the classical feature of the dentigerous cyst. However, based on occurrences, 3 radiographic variants have been identified. These are the central type, the lateral type, and the circumferential variant. The central variety of dentigerous cyst shows the symmetrical envelopment of the crown. In the lateral variety, there is dilatation of follicle on one aspect of the crown. In the circumferential variety, the entire tooth appears to be enveloped by the cyst. So here are the illustrations of the 3 types of dentigerous cysts and the corresponding radiographic images. As you can see in the central variety, the crown, the radiolucency or the cyst encloses the crown symmetrically in all the aspects. Such forms of dentigerous cysts are easy to identify because of the classical connection to the neck of the tooth. However, in the other 2 forms, based on the orientation of the radiograph, this feature of attachment to the neck may not be appreciated always. However, we would be able to find some clue regarding the same. So in the lateral type here, we can see the characteristic dilatation of the follicle on one aspect of the tooth only. If we try to follow the radiographic margin, we can see that sclerotic border is showing attachment on the other aspect as well. The circumferential type of dentigerous cyst will show a radiolucency which is enclosing the entire tooth. Such cases become difficult to identify. As you can see here, the distal aspect, it is unclear whether there is an attachment to the neck. However, if we follow the border of the radiolucency, it can be noted that there is a minor attachment appreciated here. So this is the circumferential type of dentigerous cyst. Whenever a fine needle aspiration cytology is performed for dentilation or for dentigerous cyst, the aspirate will reveal a proteinaceous pale yellow colored fluid. Sometimes cholesterol crystals may also be seen, which are seen as shimmering particles in the aspirate. Based on biochemical analysis, it has been found that the protein content of this aspirate from within the dentigerous cyst is around 50 to 70 grams per liter. It should be noted that aspirate from a cyst should not be used as a diagnostic technique. Aspirations will yield some form of clue which will help in the final diagnosis. However, for the final diagnosis, we have to perform a biopsy followed by histopathological evaluation of the specimen. So, before we understand the histopathological features associated with a dentigerous cyst, let us revise the parts of the cyst. As discussed previously, a cyst is broadly subdivided into 3 parts. You are familiar with this differentiation already. As you can see, the innermost part is also referred to as the cystic lumen. The lumen is surrounded by an epithelial lining. The epithelial lining is further surrounded by a thick connective tissue capsule. So we will be able to appreciate these 3 findings or these 3 parts in the dentigerous cyst as well, because it is a true cyst. So in a dentigerous cyst, the cystic lumen would be lined by a non-keratinized stratified squamous epithelium. This epithelial lining will generally be 2 to 4 layers thick. The lining will be composed of cells which are flattened or locuboidal in appearance. The flattened cells show resemblance to the reduced enamel epithelium, hence providing a clue to its origin. The lining is surrounded by a thick connective tissue wall formed from fibroblasts which are giving rise to thick collagen fibers. Certain parts of the connective tissue capsule may resemble the dental papilla. It should be noted that dentigerous cyst is a developmental cyst and inflammation is not usually seen. Cases of dentigerous cyst may be secondarily infected. The connective tissue capsule can also reveal presence of odontogenic rests. These odontogenic rests may be scattered throughout the capsule or may be found only in focal areas. Presence of odontogenic cell rests is not a diagnostic feature because these are occasionally seen. So here you can see small groups of this resting odontogenic cells. Furthermore, sometimes we can appreciate mucus cells within the lining of the cyst. As you can see in the image here, we have large mucus cells in the lining of the cyst. The mucus cells arise as a result of metaplastic changes within this lining. So, following the diagnosis of dentigerous cyst, it is required to be treated. The dentigerous cyst is removed by means of surgical enucleation. It should be noted here that the associated impacted or unerupted tooth is also extracted along with the cystic enucleation. Large cases of dentigerous cyst would require an alternate surgical technique referred to as marsupialization. The prognosis of dentigerous cyst is good, with minimal tendency to recur. However, the tissue of dentigerous cyst should always be submitted for microscopic examination to rule out any further complications. Here is an illustration of the technique of treatment for a cyst, that is the surgical enucleation. In this technique, the cystic lining along with the capsule is removed completely. So, a mucoperiosteal flap is raised first, followed by a creation of a window within the bone so as to expose the cyst. Once the cyst is accessible, the cyst is tried to remove completely in toto. So this complete removal of the cyst is referred to as enucleation. Sometimes the cyst may not be able to be removed in toto. In such cases, the cystic lining and the walls are removed by scraping. Such procedure is known as surgical curettage. Following the removal of the cyst, the hollow cavity is irrigated and then the defect is closed by closure of the flap. The bony defect caused as a result of the cyst will heal slowly over months by formation of new bone within the cavity. So this describes the procedure for surgical enucleation. Marsupialization is another technique for treatment of cyst. Marsupialization basically involves incomplete removal of a cyst lining. Whenever a cyst is large it is not possible to remove the entire cyst in toto. The resulting bony defect may be prone to a pathological fracture or infection at a later stage. So we follow a technique what is known as marsupialization. The term marsupialization is derived from the animal species, the marsupials, for example a kangaroo, which bears a pouch. So the technique of marsupialization basically results in a formation of a pouch-like defect. So in this technique, a mucoperiosteal flap is raised, followed by creating an access to the cyst. A window is opened providing access to the cyst, followed by which a part of the epithelial lining of the cyst is removed. The resulting cavity is packed with gauze. It is irrigated, it is packed with gauze, and a small opening is left behind. So any content which is formed would be drained slowly through this window. The idea of marsupialization is to basically shrink the tumor, shrink the cyst in size. Because the lining is not continuous, this packed gauze acts as a pathway for drainage of the cystic content. Since no fluid is produced, it will not further enlarge. Slowly the cyst would undergo compression and reduce in size. Once the cyst has reduced in size, it is removed by the technique which we discussed earlier, that is surgical enucleation. So this technique of marsupialization avoids significant morbidity associated with the technique. So this last picture here shows the direction of compression of the cyst, resulting in its reduction in size. So we have just discussed that even though dentigerous cysts do not recur and are easy to identify radiographically, however, diagnosis should always be based on histological evaluation. Because dentigerous cysts at times may show some complications. The most significant complication associated with a dentigerous cyst is the development of ameloblastoma from its lining. Ameloblastoma is an odontogenic tumor arising from odontogenic cells. Dentigerous cyst may at times give rise to a cystic variant of a tumor which is known as ameloblastoma. The photomicrograph here shows a classical representation of a unicystic ameloblastoma wherein a cyst-like space is lined by odontogenic epithelium and surrounded by a connective tissue. The cells of the lining of a dentigerous cyst may also undergo squamous metaplasia, following which dysplastic features may be seen within the cells, giving rise to squamous cell carcinoma. We had also discussed that the lining cells of the dentigerous cyst may undergo mucous metaplasia. Such cells are prone to the development of mucoepidermoid carcinoma. So, if a cyst is not evaluated thoroughly, the complications of a neoplastic transformation may be missed out. So, each and every cystic specimen should be evaluated thoroughly. That was all about the dentigerous cyst. Let us discuss about the next significant odontogenic cyst, that is the odontogenic keratocyst. The odontogenic keratocyst is a benign but locally aggressive developmental odontogenic cyst. It affects a wide age range, beginning in the second decade of life. Odontogenic keratocysts are usually asymptomatic. However, when it grows to a larger size, It will cause compression of the nerves and then result in pain. The term OKC was given by Philipson in 1956. This type of cyst characteristically produces keratin. The pathogenesis of odontogenic cyst can be described with its relation to its origin. The odontogenic keratocyst is thought to be derived from the dental lamina or its remnants. The remnants of dental lamina are referred to as the cell rests of Ceres. So these have been thought to be the origin for odontogenic keratocyst. The cells of a odontogenic keratocyst have been shown to have a higher mitotic activity than other cysts. This activity is what results in the proliferation of cells. These are also associated with release of bone resorbing factors, which will help in the expansion of the cyst. The odontogenic keratocyst shows a bimodal age distribution, shows a peak incidence in the second and third decade of life, and the second peak incidence is seen in the fifth decade of life. OKCs are more common in the males as compared to females. This cyst is common in the mandible as compared to maxilla, with the ramus third molar area being the most common site. This is followed by the first and second premolar area, which is followed by the anterior mandible. In the maxilla as well, the molar area is the most common site of predilection, followed by the anterior cuspid region, followed by the premolars. The odontogenic keratocysts enlarge typically in an anterior-posterior direction. This is a characteristic feature associated with OKCs. This feature allows the cyst to reach large sizes without causing gross expansion. It should be remembered that a radicular cyst and a dentigerous cyst shows a tendency for centripetal expansion. That means the expansion is seen on all aspects. Such form of expansion will result in cortical expansion, which would result in asymmetry. However, in case of odontogenic keratocyst, the expansion tends to occur along the marrow spaces, such that there is no significant cortical expansion. This is the reason why most of the dentigerous cysts are detected when they have caused significant bone resorption. Another feature of dentigerous cyst which makes it aggressive is its tendency to recur. This is due to the presence of a friable epithelial lining and the presence of satellite cysts. We will discuss these features under the histopathological features. The OKCs may also present as a part of a syndrome which is known as NAEVOID basal cell carcinoma syndrome or Gorlin syndrome. This syndrome is characterized by the presence of multiple odontogenic keratocysts. The radiographic feature of an odontogenic keratocyst is characteristic, but these may vary. OKCs will show a well-defined peripheral rim, which is usually scalloping in nature. OKCs may or may not be associated with an impacted tooth. However, as we have discussed, a dentigerous cyst always associated with an impacted or unerupted tooth. Larger lesions of odontogenic keratocysts shows a multilocular appearance. Smaller lesions may appear unilocular and may be confused with other cysts. As discussed already, the cyst grows in an anteroposterior direction within the medullary cavity without causing much expansion of bone. Because of its aggressive nature, the odontogenic keratocyst may cause root resorption, displacement of nerve bundles and impacted tooth, and may cause any pain. So it is important to identify or recollect the classic diagnostic or classic features of an odontogenic keratocyst. We will always be able to appreciate anterior-posterior expansion. The borders of a well-formed odontogenic cyst will always show this characteristic scalloping. We will be able to find this internal septa throughout the cystic lesion, giving rise to the multilocular appearance. The aspirates of an odontogenic keratocyst generally reveal a thick, creamy white or cheesy material consisting of keratinous debris. There is little free fluid and the contents have low soluble protein. The protein content is less than 40 gram per deciliter per liter and is composed predominantly of albumin. It should be remembered here that identification or examination of the cystic content is not diagnostic in nature. An incisional biopsy is necessary for diagnostic confirmation. However, knowing the cystic contents is important for comparison or differentiation of a dentigerous cyst with a odontogenic keratocyst. So this image shows the characteristic cheesy, creamy white aspirate which has been taken from a odontogenic keratocyst. The color is due to the presence of keratinous debris. So, histopathological evaluation of an odontogenic keratocyst which will reveal certain features. The cystic lining is composed of parakeratinized stratified squamous epithelium. The lining is 6 to 10 cell layers thick. The basal cells shows a characteristic tombstone or picket fence appearance. Interface between the epithelium and connective tissue is weak. Daughter cysts or satellite cysts may be seen within the capsule. These features may be altered with inflammation. So if we look at the image here, the photomicrograph here, we would recollect that we are already familiar with this image. Yes, we have used this image for basically understanding the parts of a cyst. So this is actually a odontogenic keratocyst. So discussing the histopathological features, we'll start with the cystic lumen. The central empty space here is the cystic lumen. This is followed by a parakeratinized stratified squamous epithelium which forms the lining of the cyst. The parakeratinized epithelium is identified by the presence of a thick keratin layer showing a pycnotic nucleus. The epithelial lining shows characteristic surface corrugations as seen in this image. Further, the basal cell layer are columnar in shape and shows hyperchromatic nucleus. The nucleus of the basal cell layer shows the characteristic palisaded arrangement. This is what is referred to as the tombstone or picket fence appearance. The connective tissue capsule is surrounding the epithelial lining. This connective tissue is composed of fibroblast and collagen fibers. It is common to see an area of detachment between the epithelial lining and the connective tissue, leading to cleft-like spaces. The epithelial connective tissue interface are generally weak in case of odontogenic keratocyst, and this is what makes the epithelial lining friable. So this makes the process of surgical enucleation difficult, leading to remnants being left over in the cystic cavity, which could be a source of recurrence of the cyst. This is a low power photomicrograph of an odontogenic keratocyst showing the characteristic daughter cysts. Here you can see the cystic lumen in the center, which is filled with keratin flakes. The cystic lumen is surrounded by an epithelial lining, which is further surrounded by a connective tissue capsule. The connective tissue capsule here shows numerous satellite cysts or daughter cysts. The presence of satellite cysts or daughter cysts are also a source of recurrence. If a odontogenic keratocyst becomes secondarily infected, it loses its characteristic identifying features. When there is intense inflammation, the characteristic identifying features are altered. As you can see in this image, these are the classical features of odontogenic keratocysts. However, due to inflammatory changes, the epithelium may lose its keratin layer and not show other features as well. In such cases, a odontogenic keratocyst may be confused with a radicular cyst. Careful evaluation and clinicopathological correlation is necessary to make this distinction. It should be remembered that radicular cyst is always associated with a non-vital tooth. So, even if a odontogenic keratocyst may mimic a radicular cyst, it might not be associated with a non-vital tooth. So, a clinicopathological correlation should also form a basis of histopathological evaluation for all cases. Odontogenic keratocysts may also present with radiographic features of a lateral periodontal cyst. As discussed before, initial cases of odontogenic keratocyst may reveal a unilocular radiolucency. In such instances, if the radiolucency is present in between the roots, it may be confused with a lateral periodontal cyst. The lateral periodontal cyst does not have the same aggressive growth potential of odontogenic cyst. So if we just rely on the radiographic findings, we might neglect the case, resulting in excessive morbidity because of the failure to identify the disease at the correct time. So it is important to perform the biopsy and identify the cystic lesion for proper treatment. Few of the odontogenic keratocysts may also be associated with some syndromes. We have already highlighted the association of odontogenic keratocyst with the Gorlin-Goltz syndrome. Treatment of odontogenic keratocyst requires surgical enucleation. For smaller lesions, larger lesions are treated by resection of the bone if the cyst expansion is large and only a thin layer of the border of mandible is remaining. In other cases where a healthy amount of bone is remaining, procedures like marsupialization followed by surgical enucleation of the cyst is done. Due to the high rate of recurrences of OKCs, following enucleation, a Carnoy solution is used. This solution basically fixes the tissue, making it easier for removal. The odontogenic keratocysts have a high overall recurrence rate of 33%. So, we have discussed the association of odontogenic keratocyst with a syndrome. This is the NAEVOID basal cell carcinoma syndrome. It is an autosomal dominant condition and is characterized by the presence of multiple odontogenic keratocysts. In addition, skin or skeletal disorders may be associated or are associated in this cyst. A diagnostic criteria has been defined to identify the NAEVOID basal cell carcinoma syndrome. To identify it as the Gorlin-Gall syndrome, two major features or one major and two minor features are required. The most significant feature is the presence of multiple odontogenic keratocysts. In addition, we may find more than two basal cell carcinoma or one basal cell carcinoma in a patient younger than 20 years of age. The multiple odontogenic keratocysts have been proven on the basis of histopathological evaluation. In addition, we may find three or more cutaneous palmar or plantar pits. The ribs may be bifid or fused, or the patient will provide a history of a first degree relative showing the NAEVOID basal cell carcinoma syndrome. In addition, a variety of minor features have been described, which could be macrocephaly or an enlarged head, one of the several orofacial congenital malformations including cleft lip and palate, frontal bossing, hypertelorism or coarse facies, other skeletal abnormalities like marked syndactyly, pectus deformity, springal deformity, Fox cerebri calcification, radiographic anomalies such as breaching of sella turcica, verbal anomalies, modeling defects of flame, shaped radiolucencies of hands and feet, ovarian fibroma and medulloblastoma. So, it requires two major or one major and two minor features to identify a NAEVOID basal cell carcinoma syndrome. So that was all about our topic for today. To summarize, Dentigerous cyst is an odontogenic cyst arising from reduced enamel epithelium. The dentigerous cyst is formed due to accumulation of fluid between the reduced enamel epithelium and the crown. The cyst is always associated with impacted or unerupted tooth. Odontogenic keratocyst, on the other hand, is an odontogenic cyst arising from remnants of dental lamina. The odontogenic keratocyst has aggressive growth potential. It shows a characteristic anterior-posterior extension. So, to conclude this topic, there are a number of odontogenic cysts which may occur in relation to the jaw. We have discussed few of the common cysts in detail. However, it is important that each one of us know about the other cysts as well. We should know at least some few points related to each of the cysts, related to its origin, its potential and its treatment. Calcifying odontogenic cyst is an important topic which results in calcification in the cyst. This topic will be discussed in the next lecture under the topic odontogenic tumors. Any doubts or clarification in relation to today's topic can be posted on the Google Classroom. The link for the same will be provided. We are in the 8th week of the lockdown now. We should avoid gestures of greeting which involves shaking of hands. I request all of us to stay at home and stay safe. With this, I would like to conclude today's lecture. Thank you for your patience.